inequality, equity, equitable access to resources, services is a big and enduring question. But the problem is that it's been stripped of data and evidence, and it's all happening based on people's whims and anecdotes and stories they tell each other. And I think what we are trying to do is really provide some real concrete conversations that we have. You'll see very interesting differences in terms of health outcomes, like for instance, child mortality, maternal mortality, density of health facilities, distance to health facilities, and many other things like poverty and mothers' education that we think are important correlates when you start to look at some of these outcomes. And what we're also trying to figure out is what is the space for moving beyond evidence in policymaking, to getting policymakers to have some intelligence in the way that they engage with the data. Somebody said that there's so much information, but there's very little knowledge. And I think what we lack is a skill to turn the information into some knowledge and a basis for action. We are not the same people, that's for sure. There are counties that look very different from the others. And yet we have the same geographic boundary, we hold the same passports, we vote in the same elections, but the outcomes of that political process has not created equitable access to goods and services. So there's a deep basis for grievance that we see across the county. And I think this is what the data is showing. The problem is that these things have not informed the political conversation. So the politics is on other things. The people who should be complaining and kicking are kicking for different reasons. They're not kicking around they're not asking why do our mothers have to die just because they wanted to have a child. They're not asking questions like why do kids drop out of school at numbers that are atrocious. Those are not the questions that are informing the political process. So what we also expect to do with data is to drive the political conversation to something that is more meaningful to Kenyans. And then what we're also trying to do with the data, for instance, what Caleb will show is that there's a sub-county in Kiambu that has worse child and maternal outcomes than the average in Turkana. Now the question is why? So you'll be sitting around here and you're thinking the central Kenya is all glory and that. No. There are serious problems and inequalities within the counties. And I think what we want to do is how do we get to the sub-county level and then get a conversation around equalization. The same conversation we're having at the national level around equitable sharing of resources should go to the counties, okay? So that MCAs are now asking the same questions that senators ought to be asking about distribution of the national cake.
When we look at inequalities and how then we can use data to be able to use it as a basis for projecting ideas, we're realizing that it is pretty complex. Portals that do not respond to needs is as good as not useful. And so one of the things we are trying to do is that we will try to use platforms like this whenever they become available as a basis for interacting with those who will eventually use our portal. There are several sides to this portal. I mean, the first side is just about literature and stories and basically what we have been able to find out. So this is our first portal. This is the first one that we are having, and this is, you can go to different sections and you can be able to get what you're looking for. Yeah, but the part that particularly concerns this discussion is a part here where we are talking about the various parameters that we thought would be reasonable for determining the outcomes of health. But as you can see that we are not just in health, we are looking at very many things at the same time. We are looking at infrastructure, education outcomes, incomes, health and sanitation. And under health, we have looked at so many things. We have looked at mobility, nutrition, access to water, sanitation, and even things like reproductive health. So we have clustered several parameters that we are looking at in this frame. And under of this, we have maternal mortalities, deliveries in hospitals, child mortalities, incidences of diarrhea, HIV prevalence, vaccination rates, because we thought then these would be very useful parameters in describing health outcomes. And of course, we have highlights, we have definitions. If you highlight there, you will be able to tell what that means. The map would be pretty flat in the absence of data. But once we put in this data, as I've already explained priorly, is that we begin to see a lot of things that happen. And so, I mean, this is important for us, especially if we are going to begin to think about interventions, or if we are going to put money, because I believe that, I don't know how the budgeting allocation is done right now, especially at the counties level. I don't know whether they do it in terms of the population size, or just because there are so many people in this place, they need to have this amount of money. But sometimes when you look at what data gives you, you begin to see that with data, you can be able to see what the first things first. I mean, data is now, helping us to probe, into things that, conventional logic may not understand. The initial phase is just to show a picture at a glance of what happens. But if you look at vaccination rates, you can see that it is really not so, there aren't very red areas. It means that, we have done quite well in our vaccination campaigns. And many of our countries would either be not so, unless now you go to places like West Pokot, and probably that's a reason, there's probably a reason why is it that West Pokot has very low vaccination rates. And so if I was in the planning and I wanted to do immunization campaigns, I would probably begin to look at these areas which seem to be apart from the rest in terms of their outlook of these variables. There are some areas that are predominantly very well off. Whichever parameter you look at, they never turn red, and this is really the thing that we are saying, that why are some counties persistently favorable in every aspect that you want to look at, and why are some, constantly flagged when we look at them. Sometimes in ecology, there is something that we call homoclimate analysis, where you can say that I want to pick the parameters of a certain place, and I want to see which other places look similar. And so there is an ecological way of looking at this thing as well, and that is what the ranking does. By the time this is done, it will not just be about health and at the county level. It will be agriculture, it will be education, it will be health, but not just at county level, but up to the ward level. And as we integrate this with other data sets that will be coming, I think it will be more useful. The biggest problem that I have, and I think it is a common problem for all of us, is the good quality data. Because a lot of this data, we used the statistical abstracts, the economic surveys, and largely we used the 2009 census data, and that is really outdated. And so we are very excited. We are getting ready so that the moment they do the new census, we will have a place we just plug it in and play.
I want to speak a little bit more on what we have started speaking about, which is the sector of health, and how can we tell inequalities, and how can we deal with them, and how we're dealing with them. First, we're going to appreciate what was there before, right? What was there in the before devolution? What was there before? And then what has changed in terms of numbers, skill mix of health workers in counties? And then what has been done to, move that change? We looked at data from the Ministry of Health. We got data from data of health workers that were seconded to counties. And then we look at some data which we struggle to get on what is happening right now. What is a change in the number of health workers? We looked at a sample of counties, and we looked like approximately 10 on what they've been doing, and then 7 on what is a change in health workers' numbers and skill mix. What we did is, as you know, there are many kinds of health workers. So we chose a sample of health workers who we thought were providing essential services at different levels. So we have higher education health workers, which is what we've listed there, and then moderate education is people who offer similar, like you can see, dental officers and dental technologists, and see, is anything changing? Our county is hiring high-skilled workers now better than they were in 2010 14 and what is driving that. Let's look at the pre-devolution situation. 3 things. At the time of devolution, there were certain inequalities, and we're going to look at 3. We see that there was unequal spending. There was obviously an equal number of health workers. And when we look at the distribution of county residents per health workers was also unequal. And we also look at the skill mix at the beginning of devolution. So when you look at this, these are numbers we got from the National Treasury, and it shows, Mandera has to come up, you guys, Mandera is red, that the amount of money that was being spent per person per capita in 2013-14 as compared to Mombasa, it's quite a big difference, right? So this is what we were trying to resolve, like how are we spending and how can we improve the spending to help Mandera, for example, reach the place where Mombasa is, okay? So we also looked at distribution, and what we saw is, yes, I use that color. What we saw is when we look at the county residents per health worker for those 10 categories that we had sampled, we see that their counties were, like for example, Mandera, there are 5,000, about 5,000 residents per health worker, and for counties like Nairobi and Isiolo, the number is significantly lower. You'll see for Isiolo it's like 577 county residents, okay, per health worker. Then now we look at post-devolution. We got from 7 counties, and what we see is an increase in health workers, a positive change in health workers, but it's not similar. So you see counties like Samburu, there's 13% increase in health workers, and counties like Turkana, for those 10 categories, 232 increase in health workers. So it's a significant increase. But the trick is just look at the numbers. Still, they don't have as many health workers as they would need for the county, okay? But there is positive change. And then when we look at the skill mix, what we realize is the classification changed in 2016. So data is not comparable as such. But for these 4 counties, we're able to compare the high education health workers and the moderate education health workers. And we see for all 4 counties, that's Bungoma, West Pokot, Kilifi, and Elgeyo Marakwet, that there's a positive change in the number of high education health workers. And also something about the spending, we now know that, first of all, we know that health function is one of the largest devolved function, all right? So it takes a huge proportion of the county total budget. So we have the counties spending on average 25% of their total budget on health, okay? And out of that, 60% goes to health workers. So this is health human resources, the largest input in the health sector in counties, all right? So we're seeing that trend as well. And then we're seeing, and this we got from Elgeyo Marakwet, is counties are employing their county residents more than other places, okay? So that's one thing the counties are encouraging. I don't know if that's a good thing or a bad thing, we can discuss. Then we're seeing in counties like, I've been to West Pokot, they built a doctor's plaza, and they budgeted for that in 2015-16 and 2016-17. Same case to Samburu, they are trying to put staff houses in their county, and they're offering means of transport like their motorbikes to go to those areas that are hard to reach. And then for Elgeyo Marakwet as well, they're trying to put residential facilities for their health workers. And then within Samburu, they promoted staff just to encourage them to stay in their county. And then we're seeing that in counties like Elgeyo Marakwet, they're improving their working environment. So they're trying to attract and retain health workers through various strategies. So now, onto the issues that I said I'll just flag out and then we can discuss. One thing and I have spoken to this, is how do we get data on this? I'm glad he said his data is from the 2009 census, but it's now 4 years into devolution. We need to update our data. And if we're going to get data from counties, does that mean I go on a Kenya road trip and then go to every county and say, I need to know how many health workers you have because this is important for policy? There has to be some way of collecting data so that we can know if you're making strides and how does this compare? For example, if Elgeyo Marakwet has employed different strategies, how does it compare to strategies that have been employed in Samburu? Is it working? What are the challenges? Benchmarking and all that. He talked about it. So there are huge data challenges, and I thought the place to get this data was the Council of Governors, but I requested for data. This has been since June last year, but nothing from them. And then obviously the Ministry of Health was like, we don't have current data, this is what we gave them. They are doing their own things, okay? So, and then the information system doesn't help because it's voluntary, so it doesn't mean it's the most updated or the most accurate data. So it's been very difficult, but what we've seen as good practice is in these 3 counties, West Pokot, Homa Bay, and Busia, they put the number of health workers in their budgets. So these are publicly available documents, so we can be able to tell in 2014 how many doctors were there and how many do they have in 2017, and what is the wage bill like. And then there's this issue on recurrent and development share. We realized as we were looking at the budgets from these counties, for example, Samburu, and Elgeyo Marakwet, and Busia, and so many counties, that they're struggling to keep within the 70-30 rule. What the PFM Acts provide is that you should not surpass recurrent expenditure of 70%. And most counties are at 69%. Some counties are even at 72% when you look at their budgets. And what it means to get more health workers is recurrent expenditure, isn't it? So what the trend has been, for example, in Samburu, in 2014, 15, and then 2016, 17, they've been spending on infrastructural projects, which means health facilities, right? So now they have all these health facilities. They've gotten dialysis equipment. They've been spending on capital expenditure. So now they are in a situation where they need to fill those places with workers, right? And what does that mean? It means you spend on recurrent, but there's this legal requirement of 70-30. What do they do to get more health workers into their country? So that's an issue that we've seen in many counties, that even if they want to recruit health workers, they're still limited by this legal provision. There's also something else that we've noticed over the years, and this speaks to the strikes, is how do we balance then national interventions and county interventions? Because counties are supposed to take control of their budgets. They have this new revenue kitty that they're supposed to spend to respond to their needs, isn't it? But there are these strikes at this level saying, as doctors, we are going to have this collective, bargaining, whatever agreement. And now it's saying, for example, nurses all across will be paid this amount of money for uniform, okay? So it's not taking into consideration, for example, can counties first afford this, all right? And do they need to spend more on the nurses they have, or do they need more nurses, all right? And if they need more nurses, and now that their extra resource is going to this new bargain, what does this mean? So there's that tension on where do we get the balance that counties can respond to their own needs, and then with this national interventions, at what point do we deal with the inequalities, all right? Because we're giving a uniform agreement. There's also a need to appreciate the size of counties, and this point we can see clearly on counties that, for example, Lamu and Isiolo. When we looked at data from 2014, we see that both counties had one dentist, right? But Isiolo is much, much bigger than Lamu. I imagine if I had a toothache in Isiolo, it would be difficult to get that one dentist. As it would, like, if I was in Lamu, it would be easier for me to get to that dentist. But those are things that we need to take into consideration. And then the issue of health facilities. Like I said, when we're talking about the skill mix, sometimes it's more efficient to spend on the low and on the moderate education health workers, because in that case, it's cheaper and it's a better way of using your money, because It's more likely for people, for example, to come to a health facility with the flu, which can be handled by a clinical officer. You don't need like a surgeon to handle such things. So those are the intricacies that we have to start asking, like to consider when we are making policy decisions. And then the last thing, which is what also Caleb said, is the need to consider within county distribution. How is the inequality within the county? And we're seeing counties like Turkana, we're looking at their data, and they're projecting to increase their health workers by a certain percentage, but the distribution of health workers in different sub-counties and different hospitals, it's responding to some inequalities, okay? So beyond the across the country inequalities, there's still inequalities within the county that we need to consider in distribution of health human resource.
So I'm here to talk about the work that we do in the department. Some of the work that we do in the department, which is mainly talk about inequalities, how to assess inequalities, or how we are assessing inequalities in access to healthcare, and from a background of the requirements for universal coverage. So they looked at the two known measures of financial protection. So they looked at impoverishment and looked at incidence of catastrophic healthcare payments. And they used the Household Health Expenditure and Utilization Survey 2013 and found generally, you can access the paper, that about 4.5% incidence of catastrophic health expenditures as of 2013. Well, this is good news in a way because 2007 had found 14% incidence of catastrophe. So you can say that the incidence of catastrophe has reduced over the past 5 years. Whether to attribute that to the interventions that have been conducted in that period is a different story. This is a description only. And if we consider indirect costs, transport, and related costs to access these facilities, the catastrophe incidence comes to about 6%. So further to that, they went ahead and tried to look at what are the remaining explanatory. So what are the things that explain this catastrophe or that contribute to or that are associated with this catastrophe? And one of the main points that I thought to bring out here is socioeconomic status. That so you could see about the richest in that survey sample, the richest quintile had about 2% incidence of catastrophe, while the poorest at about 9.9% or 10%. So an odds ratio of about 5 of incurring catastrophic expenditure if you are in quintile 1 compared to the quintile 5. But then the question is, so yeah, we've reported a reduction in the incidence of catastrophe, so should we celebrate? Is that all that we want to get? So here's a thought experiment, and you may find it actually interesting. So if you're not able to access healthcare, will you incur healthcare costs? If you are not able to access healthcare at all. So will you be able to measure how much you spent at the facility? None. So what are the chances that you will incur catastrophe? It's probably 0, right? Because you're not spending anything. So that's the problem with this instrument for measuring. It assumes that everybody is able to access healthcare and is able to actually get to the facility and access. So it's a measure that is good in places where you have high levels of service coverage, but it's a bit tricky when you actually have some people who are not accessing healthcare at all. So some work that's been going on right now is further to this, has been looking at what are the barriers to access amongst the people who are poorest in society. So went to demographic and health survey, surveillance sites in the country. There's one in Kibera, conducted by APHRC. There's one in Kilifi with the Wellcome Trust. There's one in Siaya, I think by CDC. So some qualitative interviews targeting the poorest groups. So you actually arranged these people in these surveillance sites into quintiles and reached out to the poorest, to the 5th quintile, and tried to figure out from them what are the barriers, what are the views that they have regarding the health financing reforms and regarding access to health services. And I'm just going to present 3 main views that we can just discuss later. And one is about availability. So you can see one of the comments that one of the individuals who was interviewed says that they go to the public health facilities because they don't have money. But when they get there, they find that the machines are not working. They're forced to go back home without receiving any care. So you realize that they actually have not, they might not have spent. And so if you interview, if you go quantitatively and find out how much have they spent on that visit, you might find that there's no much expenditure. But did they actually achieve the aim of that visit? So, so those are the things to consider when interpreting that. So look at another situation about affordability. So even though some of the poorest belong to financial protection schemes, so insurance coverage, health insurance subsidy for the poor, they also accessing free maternity services. Some facilities still charge extra costs that the poorest actually seem to suffer more because they're not able to raise these resources. So someone says, if care is supposed to be free, it should be free. But when you go to the clinic, it's written free outside, but when you get in there, you have to pay for something or the other. So that becomes a barrier. Okay. The other thing that happens is, now from the supply side, is since the facilities are not able to gather resources, then they lose autonomy. They are not able to make decisions that suit their population best. And so you find that sometimes some resources that they had before are not working anymore. So one of the individuals said that I was told that they don't have radiotherapy machines here, and I was told to go to a certain private hospital. And I heard that the cost is high. It's about 2,000 shillings to see a doctor, and you haven't even been treated yet. I don't have the ability to get that money. And how acceptable are these services? Even when we're designing these financing reforms and trying to ensure that we increase access to everybody. So there was some perception that the poor are being discriminated against. Okay? So you find saying that the health facility staff sometimes insult us. Okay? They tell us, why are you disturbing us here? And yet you're paid for by the government. They insult us because they prefer clients who pay by cash. Okay? Some of the poor also feel disempowered. They have no channels to provide feedback and recommendations on how to improve their access to healthcare services. So yes, you have these reforms, you have these health insurance subsidies, but you're not being heard. We don't know whether you're, we just accept what you're getting. We don't feel like we are contributing to this package that we're getting. And so generally, I think what we're learning is that universal health coverage cannot be considered in isolation. If you consider UHC as a scheme and you consider it as this insurance subsidies, this free maternity services, this user fee removal on its own, then you're not going to achieve efficient and effective care. You have to also build in staff, resources for care, and good governance. So this was written in 2012. I guess it's not something new, but just thinking back and reflecting, this is actually what I'm saying, that it's not in isolation. We have to actually bring in all the other pillars.
Today, my presentation is based off my master's project, which is the effect of participatory budgeting in Makueni in the delivery and access of healthcare services in Makueni sub-county. And what my study tries to do is, in a way, look at the intersection of new innovative practices in democracy and public health management. Makueni has emerged as a very curious case, having developed a very elaborate framework of citizen participation in budgeting process. The framework seeks to attract about 350,000 citizens in public budgeting in Makueni. And in this framework, you find that citizens are involved from the village level, then they go to the cluster level, ward level, sub-ward, and all the way to the county. So what's the relationship between PB and Makueni's health sector? Since PB comes in at the planning level of the county budget cycle in Makueni, basically through PB, citizens' inputs are collected, then they're incorporated in the budget proposal document, which is then tabled in the county assembly, then it's appraised and approved. Through PB, Makueni has been able to invest in about 53 dispensaries, medical facilities through the PB process. Yeah? This brings up to a total of about 169 dispensaries. And what Makueni has effectively done in this process is reduce the distance, the average distance to a medical facility from 10 kilometers before PBN devolution to about 4.5 kilometers after PBN devolution. Much as this is the case, you'll find that many of these facilities, most of which are dispensaries, only offer limited healthcare services should a citizen want to go to visit them. And they've also been described as operating at bare minimum. This is information coming from the Ministry of Health at Makueni sub-county. Basically, you'll see that the staffing at any one PB-initiated dispensary, they have 3 staff. They have a medical officer, they have a security guard, and a casual laborer. In one of these dispensaries I visited, I was told that the casual laborer on occasion is instructed on how to administer drugs while the medical officer is away attending to some emergency. Yeah? So much as, yes, we have the facilities, yes, we have the bragging rights to say that we have achieved the WHO target of making medical facilities accessible. What about the quality of services there? So highlighting this quote from a medical officer in one of the dispensaries, she says, there is no electricity here. We might have medical instruments for procedures, but we cannot use these instruments because we cannot keep them sterile. We need electricity to keep medical instruments sterile. We have to turn away patients who come seeking advice on family planning and antenatal care or actual child delivery. This is in spite of having the equipment here. There's no running tap water either. A proper medical center needs to have tapped running water. We do, however, have a 10,000 liter and a 16,000 liter water tank. I think the most obvious recommendation I could give to perhaps mitigate participation gaps is have participatory forums over the weekend. Yeah? Because as it is right now, participatory forums are held during the weekday working hours, in a way locking out every voice that is in formal employment. So I think one of the most outright things that Makueni could consider, I know perhaps the public officers there may feel like, you know what, that's my off day or something, but they should consider having participatory forums over the weekend. Number 2, I think Makueni needs to invest more in a holistic approach of empowering citizens in public engagement. I know that through what they call the ward public participation officers, they train citizens on how to participate, but perhaps they need to go the step further and train them that, you know what, as you participate and propose for a physical infrastructural project, you might as well also consider programmatic financing of that project as you make your proposals. Lastly, my third recommendation will be, this is more on the political side of things. I feel that participatory budgeting is a nice framework and tool for project management. Perhaps what Makueni needs to do in its design is reconfigure it in such a way that they look at the citizen as a partner in governance, not as a client in partnership in and development and governance.
It's interesting the conversation we're having because I think I've been to most of these other areas that data was being collected and represented here. In my first year, after my first year of med school, I volunteered at the New Nyanza Provincial General Hospital. So then I have an idea of how that facility runs and operates. The third and fourth year of med school, I'm in the pioneer group that started off the Kenyatta University School of Medicine. So the third and fourth year, we were training at Thika District Hospital. And then the fifth and sixth year, we relocated to Kiambu District Hospital. My first posting internship was actually at Kiambu District Hospital. So when you're talking about Kiambu County, I have that information as well. And then when I was absorbed into the ministry now, post-training, my first center was Mbagathi District Hospital, which was previously called Infectious Diseases Hospital, IDH. And then from Mbagathi, I was reposted to Pumwani Maternity Hospital. So there again, access to healthcare, the regions covering that place, that information is with me. And then I was recently now posted to Kibera South Health Center, now where I'm the medical officer in charge, so I head that facility. Interesting to note that all these facilities that I had been to previously, before being at Kibera South Health Center, most of these facilities were level 5 and level 6. And these are facilities that patients come, they don't hassle for patients because the patients are referred from these dispensaries. When we talk about equity, coming from a place where most of the patients who come to the facility already have a mindset that I may be asked to pay something, that's okay. But when now they come to a facility where they used to pay nothing, and then you start asking them, now I've treated you, but here's a prescription for the medicine, you may need to go and buy this, then that starts to bring a problem. And since June this year up to now, we've been doing mobilization of the community and informing them that as much as a few things have changed, most of the services still offered are actually free. And the only parts that you may need to pay is for a service that is not in the facility. Overall, when I look at healthcare before devolution and healthcare after devolution, when we look at it really, really closely, you realize that devolution has been such a good thing to health system in the country because of two things. One, infrastructure-wise. There are places where to get a dispensary, it would be so hard. But then post-devolution, we've had, also for political goodwill, these governors want to be re-elected. So they throw a dispensary here, upgrade a hospital there, for their own re-election, which is a good thing. Unfortunately, like someone raised it earlier, sometimes you don't think about the personnel. So whereas the infrastructure is being improved, the software, the soft skills are not being improved. The second thing that devolution has really helped us with, and it has spread it now to even areas like Kibera South, in a facility like that, you'd never find a medical doctor. But right now, we have medical doctors there. So you see the effects of devolution. There are places where you'd go and you think that the person in a white coat is actually a doctor attending to you, when in real sense, that is maybe a clinical officer. The highest, that you'd find is a clinical officer. And the community guys will be, daktari, and his word is final, you see. So devolution has really helped us. And then there's something that Marakwet County, for instance, is doing, which most of these other counties in the far-flung areas are also doing, which has really helped us with equity in terms of distribution of services. Doctors traditionally wanted to be near Nairobi or near big towns, Kisumu, Mombasa. In these areas, when you're a specialist, apart from working in the government, you can also set up your clinic and run it. And so there was no motivation for a doctor to want to stay in Marakwet or for a doctor to want to work in Marsabit. But then some county governments, interestingly, in the pay packs for doctors, which is not announced, is that they offer you like a return ticket for two in a month, like to and fro from the cities. So they lure people to go and work there with the promise that at least every month you have a return ticket to the capital city. And so that alone is something that is interesting people who have families, because at times, you know, you've already established your family here, and someone is sending you to Wajir, and you think about it, you say, let me go into private practice, okay, or you may as well just quit government. But now doctors have the incentives, and some counties pay allowances for people to work in those areas under the category of hardship allowances. So that is something that is really a plus.